Hello and welcome to another day of pw1002. So today we're going to be looking at an introduction to pharmacokinetics and pharmacodynamics. You've got a couple of tasks that we're going to be doing as well, but I'll talk those through towards the end of the PowerPoint. So as I said, today we're going to be looking at what pharmacokinetics are and what pharmacodynamics are and what they actually mean for medications as we're going through and looking at these in more detail. This is just going to be a brief overview because it is a very detailed subject. You can go into it in a little bit more detail, and I've put some extra resources on as well for you if you want to. But today we're really going to be looking at a few key areas. So the areas that we're going to look at today is we're going to be able to understand the differences between pharmacokinetics and pharmacodynamics. We're going to look at the 4 stages of pharmacokinetics and what happens to these medications as we take them. And we're going to look at first pass metabolism and what this means for medications that we actually take when we take them orally and into the body, and what this actually occurs when we've taken them. So to start with, when we're thinking about pharmacokinetics is really looking at what the body does to the drugs. So when we take our little tablet or pill or medication, or we have a topical application of something, or we look at the way that we're taking this medication, pharmacokinetics is concerned with what the body does to the drug, how the drug is broken down within the body, and what effect the body actually has on the drug. So it says for almost all drugs, the magnitude of pharmacological effect depends on the concentration at its site of action. So this means when we actually take a medication, we don't always get the full amount of medication that we take available for use once it's within the body. And pharmacodynamics is the second stage, so this is concerned with what the drug does to the body. So once that medication has been taken, once it's actually gone through into the body, it's been absorbed, whatever's happening to the medication and the effect of the medication, the effect of the body is having on the medication, the pharmacodynamics is now what does the drug do to the body. So why have we taken this medication in the first place? Is it that we've taken a painkiller because we've got pain, and this medication is now going to affect the pain sensors within our neurotransmitter sites within the nervous system? Or are we taking insulin because our body doesn't respond to insulin in the correct manner? So pharmacodynamics is related to what the drug does to the body. So when we're thinking about pharmacokinetics, this is the first part, and this is looking at the way that the body affects the drug. We have to think about the route that this medication is being taken in. So we're going to think about, have we taken this medication orally? Have we inhaled this medication? Have we taken it rectally? Have we taken it transdermally? So is it a patch? Is it a fentanyl patch, which is going to be long acting, or a GTM patch? Or have we injected this medication, or are we taking it through an IV route? So there's lots and lots of things to think about when we're thinking about our route of administration of this particular medication. Then depending on the route of administration, we then have to think about the absorption. How is this absorbed into the circulatory system? Or is it absorbed into the circulatory system? So obviously if we're taking a medication orally, this medication has to pass through the digestive system. It has to go through the stomach. Is it broken down within the stomach? Does it not be affected in the stomach and it's not broken down until we get into the small intestine? And then when it's there, is it absorbed through the villi and the microvilli, or is it going to work on the stomach itself and aspects of the digestive system, depending on what medication we're taking? Obviously, if we're taking it through the respiratory system, if it's an inhaled medication, if it's something like a ventilator, a nebulizer, or an inhaler, how is it absorbed into the areas that it's going to be affecting there? How is it taken into the body in those different places? If it's taken directly into the bloodstream because we're taking it as an IV, how is that different to the taking a medication orally? And then if we're taking a medication through IV but it's going subcut, or we're injecting the medication subcutaneously, so it might be that we're giving somebody something like insulin that's going in subcutaneously, or we're giving other medications, maybe tinzaparin. What's the difference between taking something directly into the circulatory system or having something which is going to be absorbed slower because we're injecting it into the subcutaneous tissue? We then have to think about, okay, so if I've taken our medication orally, we've got to think about effects of the digestive system. As we said, is it broken down within the digestive system? Is it broken down within the stomach? What effects do stomach acid have on our medication? Do we have to take our medication with food? Do we not have to take our medication with food? Will that affect its ability to be absorbed? And once it's absorbed into our bloodstream, thinking back to our digestive system, thinking to the way that our digestive system is designed, anything which runs into the circulatory system, into the capillaries which run parallel to the digestive system, drain straight into the hepatic arteries and the hepatic venous system, which then mean that they go straight to the liver. Before they have any effect on anywhere in the body, before they go into full circulatory effect within the body, they go through something called a first pass effect. Now we're going to look at what this first pass effect is later on in this presentation. But a first pass effect is basically how our liver will affect this medication or the products that have been absorbed into the circulatory system. And this can have major issues if a patient has liver disease or poor metabolism within the liver, or they could end up having a build-up of a hepatically metabolized drug. For example, if a patient takes high levels of paracetamol, this can have a build-up within the liver, and it can cause a liver toxicity effect, which can be damaging for the patient. So the next thing we have to think about is protein binding. Now this is whether or not a medication, once it's been absorbed into our circulatory system, can act upon the body without binding with any other proteins that we have within our system. So can a free unbound drug have an effect, or does it actually have to be bound with other proteins that are within our circulatory system or within our body before it can have a true effect on the area that it needs to affect? So for an example of this, penicillin is a very highly protein bound drug. So it actually means that we need to have the available proteins within our body for penicillin to actually have a full effect within the body on what it needs to do. We then have to think about the excretion of our medication. So once we've taken our medication into our body, how does this medication actually get taken out of the body? So how are we excreting it? How are we getting rid of it? So it's the removal or clearance of the drug or medication by the body. Is it excreted in the urine? Is it excreted by the exhalation process if it's inhaled? Is it excreted through other manners? Is it excreted through the bile? Is it excreted via other methods? So excretion is a really key area that we also have to think about when we're thinking about what the body does to the medication. The next thing that we've got to think about is half-life. Now half-life I'll go into in a little bit more detail in the afternoon seminar, but half-life is how long does it take the concentration of this medication to go down by 50% or to go down by half. So for example, if we start with something that's got 1,000 milligrams, how long would it take for that 1,000 milligrams to reduce by half to 500 milligrams? And then how long would it take for that 500 milligrams to reduce by half to 250 milligrams and so on. The half-life of a medication can actually help us to understand how often to take medication to get an appropriate therapeutic dosage. Because we know what a therapeutic dosage is, we know what a toxicity dosage is of chosen medications. So then we've got to look at how long would it take for the body to clear it before we're safe to take our next dose of medication. And this leads us nicely into toxicity. And this is obviously looking at how toxic this medication could be if there was a build-up within the body. So if we started to overdose on our medication, if we took too much of this medication, how long would it take before we actually ended up with toxic levels of the medication within our body, which could then cause issues, it could cause side effects, it could cause serious negative issues. For example, if you have an overdose of opiates, it could lead to the respiratory system shutting down. So what could actually be a problem with toxicity? And is this something that could happen easily, or is this something that could happen over time if a patient does have undiagnosed liver issues, undiagnosed kidney issues? And is this something that we have to be aware of as practitioners when we're supporting our patients? Because as we said last week, even if we aren't directly involved in the administration or prescribing of medications, we are working alongside our patients. So it is important that we're aware of any risks that our patient might have for things like side effects or toxicity events, which could be really key to whether or not our patient can actually be supported in whatever activity it is that you are needing to support them with at that particular time. Within this PowerPoint or within this presentation, I have a few little videos. Now, I'm not going to play the videos for you as we go through. Excuse me. What I would like you to do is I've put the links to the PowerPoint on Teams, on our web pages within the OneNote document that I shared with you last week. So what I'd like you to do is I'd like you to go back after you finish watching this video, and I'd like you to watch the little films. Excuse me. Because these little films are going to explain all these different things that we're talking about in a lot more detail. So this first video is going to look at the pharmacokinetics and the pharmacodynamics of medication, of what happens within the body and what the medications do to the body in a lot more detail, using lots of nice little animations and other bits and pieces that can help us. So go back, have a look, see what you can watch within these videos and see how they're going to help you.
So when you look at this word pharm,
as I said, we weren't going to watch them. So, as we mentioned earlier, there are lots and lots of different routes of administration. Now, when we think about different routes of administration, the first route of administration that most of us will think about when we think about taking tablets is orally. There are lots and lots of positive when we're thinking about taking medications orally. It's easy to do. Most people can take oral medications very simply. They're very easy to take. They're cheap and easy to mass produce generally. And it's very easy and convenient for patients to be able to take oral medications. Now, I know a lot of our patients and service users, or even ourselves, might sit there and joke about the fact that we might rattle because we take so many tablets. But the reason that so many tablets are taken orally is because it's very easy to control. It's easy for the patient to access. If we're thinking about self-administration of medication, it's the easiest method for our patients to actually administer medication for themselves. So it's probably the most common option for administration of medications. We might also have topical medications. So this might be examples such as creams. We might have antifungal creams, anti-inflammatory creams. We might have capsaicin creams. We might have ointments such as chloramphenicol or eye ointments, which are going directly to the area which is affected. So topical applications don't have the same absorption issues that maybe an oral medication has, but they are very much limited to the site of which they are administered. So if you have generalized body pains and you pop some topical anti-inflammatory gel on your elbow, it might be brilliant to work on your elbow, but it isn't going to help your knee pain. It would also have to be administered topically for that knee pain as well. Whereas a medication which is taken orally for pain relief would get to work on both the elbow pain and the knee pain. So topical applications are very, very useful in specific areas. So again, they are used for eye drops, ear drops, those kinds of things usefully because they can be controlled as to where we're popping them, and they have direct immediate effect on the area of which they're being used for. So there is a very positive use for topical medications, but they do have some negatives in that they don't affect us systemically. They do only tend to affect the area for which you're administering them. We might have a rectal route of administration. Now obviously rectal routes of administration are very good. We're going through mucous membranes again like the digestive system, so we can have very quick levels of absorption. They do go through the similar reaction to oral medications in that because they're going into the bloodstream which runs parallel to the digestive system, they do go into the hepatic venous circulatory system, so they can undergo a first pass effect in some cases. However, some of the negatives of rectal administration are that obviously it's not as easy to administer rectal medication. It's not necessarily pleasant. Patients might feel embarrassed that they don't want to be administering medication rectally. So it can be quite an invasive method of administering medication. However, in some cases, it can be really, really positive if patients can't swallow properly, if patients are having fits. You can give lorazepam and other medications rectally, which can have quite a quick effect. So it's a lot easier than starting to get injections or IVs out. So, but obviously a patient who can't swallow wouldn't be safe to take an oral medication, but you can still get that medication into a patient. So rectal routes of administration are also quite widely used for some medications, but only in certain circumstances. The next route of administration is inhalation. Now we might think of inhalation as inhalers, we might think of it as nebulizers. We also use a lot of anesthetic gases as inhalation administered medications. So inhalation methods of administration are very good if we're trying to act on the respiratory system. So obviously when we are trying to help people who are struggling to breathe, who are struggling with that through asthma or through COPD or through other issues, being able to use an inhalation method of administration can be really, really positive, especially if we're trying to affect the cells or the organs of the respiratory system. However, it's not always appropriate for all medications to be taken through an inhalation method. We might need to supplement inhalation methods, for example, with steroid tablets or steroid injections if a patient is suffering really badly with exacerbations of respiratory issues. And also there's a lot of research that's going into inhalation medications currently because of the negative impacts on the environment through the gases which are used to actually support the process of an inhaler or an inhaled gas. So there are lots of positives and negatives depending on the situation that we find ourselves in with inhaled medications. Now, buccal administration might be something that you're not really that au fait with, you might never heard of it before, but we're talking about medications which are taken underneath the tongue. So similar to rectally administered methods of medication administration, we're talking about getting back to those mucous membranes. Our mucous membranes within our body have a really good blood supply. Think about the fact that, if you bite your tongue or you bite your lip, it can recover and repair itself really, really quickly because it's got a really good blood supply. So some medications can be taken by popping the medication, which will dissolve under the tongue, or it might be for like GTN, where again you're spraying the medication directly onto the mucous membranes underneath the tongue. And these are going to get absorbed a lot quicker into the systemic blood supply because they are going into a mucous membrane which is highly perfused. But obviously taking something in the mouth and under the tongue is a lot less invasive by taking something rectally and up the bottom. Then our last route of administration is via injection. Now this might be an intramuscular injection if we're thinking about vaccines, if we're thinking about depot injections, if we're thinking about other injections which are going directly into quite a big muscle. We might be using the muscle of the arm, although in my case there isn't much muscle there. We might be using the back or the buttocks to try and get into that heavily muscular area, or the thigh, to try and get into an area of high muscle. Thinking back to our anatomy and physiology sessions, our skeletal muscle system is very, again, well perfused. It's very vascular, so it can help for that absorption within the body to get into our systemic circulation quite quickly. But again, it is quite an invasive procedure. Some people don't like needles or injections. And it's the same with some of the others. Obviously, intraosseous, we're talking about injections directly into joints or injections directly into bones. Again, depending on what you're having the injection for. If you're having an injection of steroids maybe, or local anaesthetic into a joint which is injured or damaged, this gets to work directly onto that area, and it might be really, really beneficial for that particular area. But it isn't systemic. It won't necessarily work in the same systemic way. They tend to stay local to the area of which they are injected. We also have intravenous administration of medication. Obviously this is done by the insertion of a cannula, and then it's going directly into the circulatory system. So it might be that we are giving a patient intravenous antibiotics or intravenous fluids or other medications that are being given intravenously. This cuts out the first pass effect, and this starts to actually cause the medication to get directly into the systemic circulation very, very quickly. So it can start to have a much quicker effect on the body or on specific areas, whereas an orally taken tablet has to go through the digestive process. So it might actually take 20 minutes, half an hour, up to a couple of hours before it actually fully gets into the through the digestive system, into the systemic circulation, to actually have a therapeutic effect on the body. And then lastly, when we're thinking about our different methods of injection, we might have a subcutaneous injection. So this might be into the subcutaneous tissue within the belly, might be the subcutaneous tissue of the front of the leg, and this isn't directly into a muscle or directly into the circulatory system, but it's into these cutaneous layers of the integumentary system, which don't have quite as good of a blood supply as the musculoskeletal system, but they are going to be absorbed slowly over time, which when we think about injections that tend to be given subcutaneously, such as insulin or tinzaparin, these are things that we want to have a slow release of this medication over a period of time to actually have a therapeutic effect upon the body. So there's lots and lots of different ways when we're thinking about our routes of administration as to what are the positives of these routes. So are they quick? Are they easy? Are they very easy for the patient to take themselves? Are they convenient? Are they trying to access a very specific area, such as a topical gel or a local injection? Or are we trying to get a more systemic effect very quickly in the way that we might then decide that actually this patient needs to have an intravenous method of administration? We have another little video here. This lady is going to go into more detail about different routes of administration of medications, looking at positives, looking at negatives, looking at why we might use them and what some of the benefits are of different routes. As I said, I'm not going to watch the videos with you now. I need you to go back and watch these videos at a later date.
Okay,
So the last little bit that we're going to look at for this particular PowerPoint on this presentation is the first pass effect. So as I've mentioned briefly earlier in the presentation, when we're thinking about the effect that the body has on a medication, one of the things we have to think about is the effect of the liver and the way that the liver starts to metabolize these medications when we've taken them. And this is called the first pass effect. Now, as I said earlier, this is generally only relevant for medications which are taken orally, because orally taken medications are usually absorbed within the small intestine. If you think back to your digestive system, we take in our food down our throat, down our esophagus, into our stomach. Things are mulched up, are digested within our stomach, and then they pass into the small intestine for absorption. And the small intestine contains the villi and the microvilli to up the surface area to mean that our absorption of nutrients and other things that are within our digestive system can be completed quickly and efficiently. But because of the way that our bodies are created, the digestive system works, our circulatory system, which runs parallel to our digestive system, runs straight into the portal venous system, which means that anything which is absorbed through the small intestine is transported directly to the liver before it goes back into general circulation to go to the heart to be circulated around the body. So when these medications hit the liver, or these products of the broken down medications hit the liver starts to metabolize most of the chemicals which are within these medications. So actually a large percentage of oral medications are destroyed. So before it actually has any therapeutic effect within the body, our liver has already taken a large percentage of the medication that we're taking. And this is what the first pass effect is. And this is sometimes why oral doses might be greater than doses that are given in different ways. For anybody who has ever worked with patients who have been prescribed IV paracetamol, at first, if you're having a conversation with a patient about the fact that they're going to be prescribed IV paracetamol for the pain, they hear the word paracetamol and they sit there and they say, well, paracetamol's not going to touch this. But what they aren't aware of is the fact that when we take an oral paracetamol, because it is taken straight to the liver and it undergoes the first pass effect, we might lose up to 50% of the paracetamol dose when we actually take a paracetamol, or the 1 gram of paracetamol, which is an adult dose. Whereas if we take 1 gram of paracetamol as an IV dose directly into the circulatory system, this dosage, or this first pass effect, isn't actually occurring. So actually a patient will be getting the full dosage of medication, or the full gram of paracetamol, having a therapeutic effect on the body, instead of maybe the normal 50% of a therapeutic effect which is left after first pass metabolism. So patients might actually be really surprised how much a gram of IV paracetamol can actually affect their body and reduce their pain compared to when they would take a gram of paracetamol orally. The first pass effect can also have negative impacts upon some medication. And this is why, as we said earlier, we take GTN as a buccal, we take it under the tongue, we spray it within our mouth. And this is because actually if we took GTN as an oral tablet, it would have to be a much higher dose because GTN has a really high first pass effect. So actually quite a lot of the dosage of GTN is taken out of the body or taken out of the circulation excuse me, before it has an effect on the body. So they've had to think of other ways for us to actually be able to administer GTN for it to have a therapeutic effect at a lower dose, which is safe for the patient and has less side effects. And this is why injections usually have better outcomes. So if we're thinking about an example such as an antibiotic, if a patient has an infection which isn't responding to a traditional dose of oral antibiotics, they may need to go to be admitted to have a session of IV antibiotics, because even though they might be being prescribed exactly the same amount of that antibiotic, because it's going in through an IV, they're actually getting the full therapeutic effect of the full dosage, as opposed to a half therapeutic effect after the first pass effect has taken place. So again, we've got another little video here explaining the first pass effect in a little bit more detail. Go back, have a look, have a watch, see what you can find out.
Today let's talk about the first pass effect.
So last but not least, this starts to lead us on to the tasks, what I actually want you to do for the rest of this morning's session. So first of all, I'd like you to go away and to look at this list. Excuse me for a second. And to think about providing yourself with a definition of what is pharmacokinetics, what is pharmacodynamics, what's the difference between the two, what is absorption, what is distribution, what is metabolism, and what is excretion when we're thinking about pharmacokinetics and pharmacodynamics, and what is the first pass effect. We also have, not included within this presentation, but within the OneNote and the Teams page, a workbook. And within that workbook, there are a couple of sections that I'd like you to have a look at. And one of them is looking at these things in a little bit more detail again, and being able to go back to what do they mean, how do they apply. But also thinking about some of the medications that we started to look at last week, and we started to identify where some of these medications fell as far as were they prescription only, were they general sales list, were they over the counter, but actually starting to go into a little bit more detail about some of those medications. So within the workbook, you'll find some sections that want you to say, you know, what is the medication used for? Does it have any other names? What's an average dosage? Are there any contraindications or things that we shouldn't take it with? And how we should also be aware of these things. So really, by the end of today, I'd like you to have, or by the time that we have our discussion session in the afternoon, what I'd like you to have done is to watch the whole of this presentation, to have gone back to the physical version of this presentation and watch those 3 little videos. They're only, I think they range from about 2 or 3 minutes to about 10 minutes each, to have a look, get those principles explained to you in a little bit more details, and then to have a look at that workbook. Don't worry about the maths sections, don't worry about some of the workings out sections, because we're going to cover those later on, but actually try and answer the questions around pharmacokinetics, pharmacodynamics, and actually looking at those medications in a little bit more detail. Sorry, the window cleaner just started cleaning my window and scared me to death then. I do apologise. I just saw this big brush attack the window. And then lastly but not leastly, any questions that you have a think. You know, if you have questions, pop a question on Teams, I can make an answer. We can have a discussion on there. Email me, talk to me, or write them down, and then in the afternoon we can discuss them together, because there might be questions that lots of you have, or different thoughts that lots of you might have. So feel free to have a discussion, bring your answers together, we're going to have a really good talk in the afternoon about some of the things and some of the concepts that this presentation has kind of introduced you to. So have a lovely day or have a lovely morning, and I shall see you this afternoon. Bye.